Welcome to the Explainer. So, imagine for a second that a pet's immune system is this highly trained elite army. Normally, its whole job is to defend the kingdom against outside invaders. But what happens when that army gets confused, totally goes rogue, and starts attacking the very kingdom it was sworn to protect? Well, that is the terrifying reality of primary immune-mediated disease in our veterinary patients. Today, we're going to master the pharmacological arsenal we actually use to stop that rogue army right in its tracks.
It's a clinical nightmare we face all too often, right? You've got a crashing patient, you deploy your standard, trusty steroids, and nothing happens. Or even worse, the patient starts developing severe side effects before the disease is even under control. So, what do you do when your frontline defense just totally fails to stop an immune system in overdrive? You need a tiered therapeutic arsenal, and that's exactly what we're going to build out today. Look, this isn't just about memorizing drug mechanisms from a textbook. This is about saving actual, real-world patients battling severe, life-threatening conditions, like the feline patient you're seeing right here. Mastering these medications, knowing exactly when, why, and how to deploy them is absolutely crucial for restoring the quality of life for the animals sitting in our exam rooms. Okay, let's dive into our roadmap for today. We'll be hitting 1. Immune-mediated disease basics. 2. First-line defense, glucocorticoids. 3. The calcineurin inhibitor, Cyclosporine. 4. Purine inhibitors, Mycophenolate and Azathioprine. 5. Pyrimidine synthesis inhibitor, Leflunomide. And 6. Choosing your therapeutic strategy. Let's get started.
Section 1. Immune-mediated disease basics. When the body attacks itself. The absolute golden rule here. Primary immune-mediated disease is a diagnosis of exclusion. We have to rule out secondary triggers like recent medications or underlying infections before we even think about deploying heavy immunosuppression.
And this right here is the clinical battlefield where our drug arsenal is going to be deployed. We're looking at diseases that literally destroy platelets, like ITP, or wipe out red blood cells, like IMHA. We're dealing with intensely painful joints in IMPA, severe skin flare-ups in atopic dermatitis, dangerous neurological inflammation in MUE, and really frustrating chronic gut issues. These are intense, aggressive conditions, and they require equally aggressive countermeasures. Section 2. First-line defense, glucocorticoids, the reliable broad-spectrum commander. These are our rapid response troops. They hit incredibly hard and fast, but that raw power definitely comes with some collateral damage.
So how does this commander actually work? At the cellular level, glucocorticoids are nuclear factor kappa B inhibitors. They literally pull the plug on the production of inflammatory cytokines and induce apoptosis. Basically, they force those rogue lymphocytes to self-destruct. It's a massive, broad, non-specific shutdown of the entire immune response.
What's really fascinating here is how the potency and duration just completely shift depending on the drug. This perfectly illustrates why we have to pick the right tool for the job. Prednisolone is your standard baseline, sure, but look at Dexamethasone. It's 7 to 10 times more potent, which is exactly what you want for a hospitalized dog with severe protein-losing enteropathy. Then you have budesonide, a locally active steroid. It is an absolute lifesaver for treating chronic enteropathies in diabetic cats where you desperately want to avoid those systemic steroid spikes. And methylprednisolone acetate? That's the long-acting injectable we reserve for those fractious cats who are just absolutely not going to take daily pills.
If our steroid commander has one superpower, it's absolutely speed. You will so often see clinical improvement within just 48 hours of administration, and they hit a steady state by day 4. When a dog is actively destroying its own red blood cells, you do not have weeks to wait. You absolutely need that 48-hour rapid onset.
But, that kind of raw power comes with serious collateral damage. We're talking PUPD, insane panting, muscle wasting, thinning skin, and a very real risk of hypercoagulability. It's these unacceptable side effects that often force us to call in our second-line agents. Oh, and a crucial, totally non-negotiable clinical note for you. Cats physically lack the hepatic ability to convert prednisone into the active form. You absolutely must always prescribe prednisolone for your feline patients. No exceptions.
Section 3. The calcineurin inhibitor, Cyclosporine, the targeted special forces approach. Because when the commander's collateral damage is just too high, or the disease is being incredibly stubborn, we have to deploy the special forces.
So if steroids are like a broad-spectrum bomb, cyclosporine is a sniper. It's a calcineurin inhibitor. It very specifically blocks T-cell proliferation and activation. It's a highly targeted cellular blockade that actually spares other parts of the immune system, which makes it a fantastic long-term maintenance drug. We call in these special forces for some very specific battles. For perianal fistulas, it's incredibly effective, sometimes even as the sole agent. It's also fantastic for atopic dermatitis, polyarthritis, and chronic hepatitis. But here's the catch. You have to be patient. It can take up to 2 to 4 weeks to actually reach a steady state, which is exactly why we often start it concurrently with a rapidly acting steroid.
Okay, formulation is absolutely key here. You really have to use the ultramicronized modified formulation, like a Topica, to get predictable absorption. The non-modified versions are just way too erratic. Now, side effects are usually GI upset, which you can kind of mitigate by freezing the capsules or giving them with just a tiny bit of food. Also, here's a crazy fact. Dogs on cyclosporine are actually 7 times more likely to develop opportunistic fungal infections, so keep a really close eye on those non-healing wounds.
Section 4. Purine inhibitors, Mycophenolate and Azathioprine, halting DNA and RNA production.
These drugs literally sabotage the immune system from the inside out. By inhibiting purine synthesis or antagonizing its metabolism, they halt the production of DNA and RNA in lymphocytes. They basically starve the T and B cells so they physically cannot multiply and continue their attack on the body.
This is a classic head-to-head comparison of the real-world trade-offs we have to make in the clinic. You've got mycophenolate on one side. It is fast, hitting steady state in just 4 to 5 days, and we even have an IV form for crashing patients. The drawback? Severe dose-dependent diarrhea. But then you have Azathioprine. It's slow, taking weeks to really kick in, but the huge advantage is that it's highly cost-effective for large dogs because you can taper them down to every other day dosing. The massive drawback here, though, is that it can cause subclinical hepatotoxicity in dogs, and it is strictly, fundamentally off-limits for cats. They have a fatal inability to metabolize it, so never, ever give it to a cat.
So when do we actually use these? For the heaviest hitters. IMHA, ITP, myasthenia gravis, and meningoencephalitis. If your patient is transfusion dependent after 7 days of steroid therapy or presents with a really life-threatening illness, this is when you reach for these specific secondary agents to regain control of the situation.
Section 5. Pyrimidine synthesis inhibitor, Leflunomide, the alternative blockade.
Okay, so if purine inhibitors block one pathway of DNA synthesis, leflunomide blocks the other. It's a pyrimidine synthesis inhibitor. Acting almost entirely through its active metabolite, teriflunomide, it shuts down T-cell proliferation and stops B cells from churning out those destructive autoantibodies. It's a fantastic alternative mechanism when your other drugs are just failing to get the job done.
Looking at leflunomide's profile, it takes about 1 to 3 weeks to hit steady state. It's a real lifesaver for MPA and refractory colorectal polyps. Interestingly, unlike in human medicine, we actually do not use a loading dose in dogs and cats. You do need to monitor for some unique side effects, though, like unexplained hemorrhage and leukopenia. And here's a great clinical tip for you. If you aren't seeing the response you want, therapeutic drug monitoring for leflunomide, and actually for cyclosporine too, can be performed at Auburn University to help you dial in your exact dosage.
Section 6. Choosing your therapeutic strategy. Tactical deployment in the clinic. We have all these weapons, so how do we tactically deploy this arsenal in the real world?
It really comes down to these 5 tactical steps. First, look at comorbidities. If you've got a diabetic dog, you might try to bypass high-dose systemic steroids entirely and lean on cyclosporine instead. Second, evaluate owner finances. Azathioprine might honestly be the only affordable option for a Great Dane. Third, how fast you need it to work. Fourth, monitor for unique adverse effects. And whatever you do, never combine 2 drugs that both cause severe myelosuppression. And finally, step 5 is absolutely critical. Taper slowly. Taper only 1 drug at a time, and never reduce by more than 25% every 2 to 4 weeks. A rush taper is honestly the fastest way to trigger a devastating relapse, and nobody wants that.
So, we've covered the whole arsenal: the rapid response of glucocorticoids, the targeted precision of cyclosporine, and the DNA-halting power of purine and pyrimidine inhibitors. Knowing the unique mechanisms and the real collateral damage of each of these medications, how are you going to change your prescribing strategy the next time you face a rogue immune system in your clinic? Think about it. Keep your focus sharp, stay curious, and use this tiered strategy to save those patients. Thanks for joining me on this explainer.